Hi guys, what's up? Today we're going to talk about heart failure, especially the management strategies of the heart failure. So let me write the topic here: heart failure, right? Strategy of heart failure management. So before really going into deep into this topic, let's get into first how the heart failure happens. What is the main thing in the heart failure? In heart failure, the first thing is the cardiac output decreases. The cardiac output decreases, right? So when the cardiac output decreases, what happens is you decrease the blood pressure. You decrease the blood pressure, right? So when the blood pressure decreases, your sympathetic autonomic nervous system kicks in. So your sympathetic autonomic system kicks in, right? So now this, let me draw this way. Sympathetic autonomic nervous system kicks in. So it affects it affects your kidney. So it affects your blood vessels, right? And the next thing, it affects your heart. So these are the three main organs the sympathetic autonomic nervous system acts on when your blood pressure decreases. Now, what it does in the cardiac muscles. So sympathetic autonomic nervous system, when it fires, it increases. Let me erase the topic here so that I can get more space. So when it acts in the heart, it increases the contractility, right? And it increases heart rate. So this is the thing, what happens in the heart. Now what happens in your kidney? In kidney there is beta-1 receptor, right? These are mediated by beta-1 receptor, and this, in kidney there is also beta-1 receptor. And when the beta-1 receptor is stimulated, what happens is the renin release is increased. So it increases renin release. Renin increases in the blood. Now, what happens when the sympathetic autonomic nervous system kicks in into the blood vessels? What happens? There is alpha-1 receptor, and by the alpha-1 mediated action, there is vasoconstriction. All right, there is vasoconstriction that is mediated by the alpha-1 receptor. Now, when there's vasoconstriction, that means there's increased afterload. You know why there's increased afterload? Because the total peripheral resistance increases when there is vasoconstriction, and it causes rise in the afterload. So this is the thing up to here. Now, let's come to the kidney. When the renin release increases, what happens is it ultimately increases the production of the angiotensin 2. I'm writing very small letters, handwriting, because I will need more space. So I hope you are seeing it clearly. Now, when the angiotensin 2 is increased, what happens is it increases the aldosterone level. Right? When the aldosterone level is increased, what happens is it causes sodium and water retention. Right? Now, when there's sodium and water retention, what happens is you increase the blood volume. Now, you see, when there is increased volume of blood, what happens is you increase the capillary pressure in the capillaries, right? You increase capillary pressure. Let me write in short form so I will utilize less space. So when there's increased blood volume, there is increasing capillary pressure. And when there is increasing capillary pressure, what happens is there is increasing capillary filtration, right? And when there's increasing capillary filtration, because when there's capillary pressure increase, there is a more hydrostatic pressure in the capillary, so the vessels will become more permeable to the water. So the water oozes out from the capillaries, and now what happens as a result? What happens is you will see edema. You will see edema, right? Now, again, another manifestation of the cardiac output decrease is you will see increase in venous pressure. Increase in venous pressure. You know why? You know why there is increase in venous pressure when there is decrease in cardiac output? Because when the heart is pumping out less blood, that means more of the blood is remained or retained in the venous side, right? When the more amount of the blood is retained in the venous side, what happens is there is pooling of blood. When there's pooling of the blood in the venous side, that means the venous side has much more pressure because there is more blood pulled in there, right? So the venous pressure increases. When the venous pressure increases, again, the same story is repeated. That is, the capillary pressure is increased. When the capillary pressure is increased, again, the same story, that is increased capillary filtration. When there is increased capillary filtration, again there is increased capillary filtration. When there is increased capillary filtration, again, you will see edema. So edema is one of the manifestations of the heart failure. Now let's get into the next manifestation. So the first manifestation was decreased BP and increased sympathetic activity. And its manifestation in the heart, we saw it, and in the kidney we saw it, and in the basal we saw it. Now let's get into the next manifestation of a cardiac decrease, and that's your increased systolic increase and systolic volume. You know what systolic volume is? When your heart pumps the blood, very minimal amount of the blood is remained in the ventricle, especially the left ventricle. But in the pathologic heart, when the heart is not being able to pump all the blood that's present in the left ventricle, more amount of blood is remained in the left ventricle. So that means when the heart is not pumping through its all the capacity, more amount of blood is remaining in the heart. That means increase in systolic volume. In systolic volume is basically the amount of blood that's remaining in the heart after the systole. So when less amount of the blood is ejected from the heart, more amount of the blood is remaining in the heart. This is basic rule, right? Now, when the insystolic volume is increased, that means when the heart is filled, when it is already filled with some blood, that means the end diastolic volume, the volume of the blood inside the heart at the end of its diastolic phase, that increases, right? So when the insystolic volume increases, what happens is you will see increase in the end diastolic volume. So I think this line is clear to all guys. So when the end diastolic volume increases, that means you increase the preload. You increase the preload, right? So basically, what is preload? Literally, what preload means, the load that is beforehand. What is afterload? That means the load afterhand. So afterload is given by the total peripheral resistance, but preload is given by the volume of the blood you have in your body. So when there is diastolic volume increase, that means the heart has to load more blood in it before pumping it out. So preload is increasing the heart, right? Now when preload is increasing the heart, interesting thing happens, but not very interesting for the patient, right? Interesting to learn, by the way. Anyways, so what happens when preload increases? When preload increases, now there's a law, and that is basically the law of physics, but that comes handy in the physiology also. That means when something is stressed more, then it contracts more. So the law is called Starling law, Frank-Starling law. So when there is increased end diastolic volume, there is increased preload. When there is increased preload, now the heart expands more. When the heart expands more, what happens is it contracts more. So this is the compensation mechanism, right? When the heart stretches more, let me write another box here, dilated heart. Dilated heart, right? So when the heart gets dilated, what happens is it gets more contraction because that's a compensation mechanism, and that's according to the physical law. So this is Starling compensation, okay? And when there's compensation, what happens is there is increased strength of contraction. So basically, what was our problem in the heart failure? There was actually decrease in the strength of contraction of the heart, and due to that, there was decrease in the cardiac output, right? So now the heart has compensated it. The heart has increased the strength of contraction, right? Now, when the contraction strength is increased, the heart will again pump more blood, but this is for a certain time. Now, when the heart, compensates, everything has a limit, right? So the heart cannot compensate all your life for your 80 years, 90 or 100 years. So for some time it will compensate, but once its limit is crossed, now decompensation phase starts. This is decompensation. You see, now there is decompensation. So there is decrease in the strength of contraction. Right now there is decrease in the strength of contraction. Again, when there is decrease in the contraction strength, what happens is, again, you will get decreased cardiac output. So these are the things. And now one thing, what is missed in this flow chart is when there's decreased output, what happens is there is decreased renal blood flow also. And when there is a decreased renal blood flow, again, this stimulates the kidney to secrete more renin, and again, the same pathway is followed. Okay, now you see, mainly there are four things that happens when the cardiac output decreases. The first thing is there is decreased BP, and the second one is there is decreased renal blood. Actually, these comes together. Anyways, I made a different point because these are more important from exam point of view. And again, the next thing is decreased venous pressure, and there is increased end systolic volume. And all this leads to the overactivation of the sympathetic and autonomic nervous system, causes increased heart rate, increased contractility, and increased renin production, and increased vasoconstriction. And the increased venous pressure leads to increased capillary pressure and increased filtration in the capillaries, and that leads to edema. And this also leads to increased renin, also leads to increased capillary pressure, increased capillary filtration, and edema. And the next thing is cardiac output increases the end systolic volume, and that finally increases the end diastolic volume, and that increases the preload, and that causes dilation of the heart. And by Frank-Starling law, the heart will compensate for a certain period of time, and that will increase the strength of the contraction, but after some time the heart can no more compensate. So what happens is the heart will face the decrease in the strength of contraction. Now cardiac output again decrease. So this is the vicious cycle the heart will have to face once it gets failed, right? So now, what are the management strategies in this heart failure? Now that you understand the mechanism of heart failure, now let's put the drugs into this diagram. So let me use the next pen so it'll be easy for you guys. So you see, everything is good to a certain limit. Even if it is a good thing, more of a good thing is very bad. So, see here, the sympathetic nervous system was activated to compensate, right? But to some extent, activation of the sympathetic autonomic nervous system is good. But when it happens more, when the sympathetic nervous system activates more, then there is increase in heart rate. So it increases so much that it may cause arrhythmia also. So we have to control the heart rate. You have to control the heart rate. So we can intervene here. And next thing is when there's increased contractility, we also can control, let's not use the word decrease, but let's use the topic, use the word control, right? Or basically in the acute phase of a congestive heart failure, the contractility of the heart is decreased. So we can increase the output of the heart, cardiac output, by increasing the contractility. So we can, in simple word, what I mean to say is the basic problem in the heart failure is decreased contractility, right? So we can increase contractility by using a drug. So here we can intervene. And the next place where we can intervene is the vessels. If we dilate the vessels, we will decrease afterload. When we will decrease afterload, what happens is it will automatically decrease the workload for the heart. So this also can be intervened. Now, next thing is, we can actually decrease the preload, because the preload is doing all the problems. When there's increased preload, the heart will dilate more, and the heart will, have to work more, right? Because of increased strength of contraction. So we don't want this to happen more. So we control it by using some drugs that help to decrease preloads. For example, one we can use diuretics, because by diuretics you can get rid of the volume in the body. The next thing is you can venodilate. When you venodilate, what happens is all the blood gets pulled in the right side of your body, or I meant to say the venous side of the body. So when the more amount of blood is remained or pulled in the venous side of the body, then it will get less output. The cardiac will give less output because more of the blood is pulled in the venous side. So when there's less cardiac output, then again, what happens is when there's less cardiac output, or actually the problem is less cardiac output already, but we're trying to control here. We're not decreasing actually, so that we can decrease the cardiac workload. So if we decrease the preload, the heart will dilate less, and when the heart is less dilated, so the contraction strength is decreased and the workload to the heart is decreased. So that's what basically we want to do with the heart failures, right? So this is the next place where we can intervene. Then now the next thing, so this contractility and this strength of contraction increase, these are the same thing. So we can intervene right here. These are the same thing, right? So one strategy is to increase contractility, the next strategy is to decrease heart rate, and the next strategy is to dilate the veins, or the basals, not the veins. And the next thing is we can use diuretics and venodilates. So one is strategy A, next is strategy B, this is B strategy, and this is C strategy, and this is D. Now there's one very important thing. You know what? When there is so much compensation, there's increased strength of the heart, right, for its contraction. But when you utilize your muscles for a long time, the muscle gets hypertrophied, right? So when you increase contractility and you utilize you make the heart to contract more, what happens is the heart's muscle, the cardiac muscles get hypertrophied, especially the left ventricle's muscle. So we call that left ventricular hypertrophy. So hypertrophy to some extent can be good, but a good thing also, even if it's a good thing, if it's more, then that is bad. So when you get left ventricular hypertrophy for a longer time, then what happens is the left ventricular hypertrophy will progress into the cardiac remodeling. So what is cardiac remodeling? Cardiac remodeling means that there is loss of the myocytes in the heart, and finally that leads to fibrosis of the myocytes. So when there's fibrosis of myocytes, there's no conduction, and when there's no conduction, then the heart can't work. So basically, this compensation for a longer time will lead to remodeling of the heart. Now, in this new world, this controlling the remodeling of the heart has been the greatest issue. So the first thing is first, we have to stop the remodeling of the heart, because congestive heart failure patients, these are the patients who will face the chronic problem. So in chronic, pattern, in a long term, what happens is they will get their heart remodeled. So we have to stop this. So what are the two main things that causes remodeling of the heart? Now you see from this poster, the first thing that causes remodeling is increased this aldosterone. You know why I wrote the number here? Because if it was not for aldosterone, then it would not cause increased blood volume. So if there was no increased blood volume, there would not have any increase in preload. So there would not have been so much dilated heart for a longer time, and that would not have caused the cardiac muscles to remodel. So the first culprit for the cardiac remodeling is the increased aldosterone. So we can intervene here, right? And the next thing is where we can intervene is the sympathetic autonomic nervous system, because the sympathetic nervous system is being activated more, it has caused all the problems, right? But we cannot basically stop all the sympathetic nervous system at once. We specifically address these things, but one thing we can specifically target on is the aldosterone. So to stop the remodeling of the heart, we have to intervene the increase in aldosterone and increase in the sympathetic autonomic nervous system. And increase in the sympathetic autonomic nervous system, we have actually specifically addressed that problem. Now we can decrease aldosterone, right, by using next type of drug. And let's give this strategy the name E. So we have now strategy A, strategy B, strategy C, strategy D, and the strategy E. So now, since the heart rate is mediated by beta-1 receptor, we can give beta blocker. Right? And you know that while using beta blocker in the heart, you always go for cardio-selective beta blocker. You never want to use beta-2, because beta-2 has tendency to cause bronchospasm or vasospasm. So you don't want to give the patients beta-2 blockers who have vasospastic disorders already, because that will precipitate vasospasm or bronchospasm, which is basically asthma. So you give beta blocker. Now the next thing is vasoconstriction. So what you want to give for to intervene the vasoconstriction, you want to give alpha-1 blockers. Can you name some of the alpha-1 blockers? Like prazosin, doxazosin. Now let's not get into there. Now let's get to the strategy. In the strategy A, we'll come later. Okay, and in the strategy D, I already told a little bit of it. So we can use diuretics. Diuretics helps to get rid you from the blood volume. So it will decrease the blood volume, it will decrease the preload, it will decrease the dilation of the heart, and so on, so the process follows. And when you venodilate, again, I already told you, when there's venodilation, there's blood pooling, and it decreases the cardiac output. When the cardiac output decreases, then the dilated heart will be dilated very much less. And when the heart is dilated less, then strength of contraction also decreases. Now it helps the heart to decrease its workload. So this is the strategy B, strategy C, strategy D, and now let's come into the strategy A. So why I discussed later the strategy A, because the drugs we use for strategy A, like digoxin, these are very dangerous drugs. So these are very, digoxin has, very low therapeutic index. Low therapeutic index means if you use a drug around double of its dose, it may kill the patient with severe arrhythmia in the patient. So you don't want to give digoxin as a first-line drug. So digoxin, in which case you want to use the digoxin? You can use the digoxin in a certain acute congestive heart failure, where the patient has severely decreased contractility of the heart. So you give the digoxin with very small dose and very in a regulated dose, in a very highly monitored dose. Because and while giving digoxin, make sure you have the digoxin antibody by the side of the patient's bed, because anytime the patient may get toxicity, right? And this is the important thing that we have to know. Now, why digoxin? I've already told you to increase the contractility of the heart, and so let me write the drug here, digoxin. So this increases the contractility of the heart. Now, we have discussed strategy B, strategy C, strategy D, strategy A. Now let's come to the E. This is much more interesting. So what the drug strategy E does, it decreases the aldosterone level in the blood. So what are the drugs that decreases the aldosterone level in the blood? Let me write it here. The drugs that decreases the aldosterone in the effect in the blood are, the first one is your S inhibitors, or with ACE comes ARBs. And the next one is you want to get spironolactone. The next one is you want to give beta blocker. You know why? You have to know the reasons behind this. Why? Why ACE inhibitors or why ARBs? You know, ACE inhibitors, what it does, ACE inhibitors actually inhibits the angiotensin converting enzyme. This angiotensin converting enzyme, what it does is it converts the angiotensin 1 into the angiotensin 2, right? So when the angiotensin 2 is not being able to form, then the aldosterone level decreases. So if this is inhibited by this ACEI, then aldosterone level decreases. When the aldosterone level decreases, no sodium water retention, no blood volume, no increase in capillary pressure, no increase in capillary filtration, and no edema. And again, when there is no sodium water retention, it also does not cause increase in diastolic volume, and it does not increase the preload. So this is how this ACE inhibitors or ARBs help. The mechanism of action of ACE inhibitors and ARBs are similar, but not exactly the same. We'll discuss that in next video. But for now, just trust me that these two drugs decreases the aldosterone effect in the body. Then the next thing, how the spironolactone is going to help with the cardiac remodeling. This spironolactone is basically, this is the aldosterone receptor antagonist. So when this is aldosterone receptor antagonist, it does not let the aldosterone to act on the principal cells of the distal convoluted tubule. So when it does not let the aldosterone to act on the principal cells, so let me make the figure, matchstick figure here to make it easy. So if this is your distal convoluted tubule, here is a cell, and this cell is principal cell, and there is also another cell that is intercalated cell. So in the principal cell, there is aldosterone receptor. So what spironolactone does is it blocks this aldosterone receptor. It blocks this aldosterone receptor, and when the aldosterone receptor is blocked, it cannot withdraw the sodium in, and it cannot throw the potassium out of this cell. Now you see? So it cannot draw the sodium in. So when it cannot draw the sodium in, the water cannot follow the sodium. So water and sodium is not retained in the body. So spironolactone helps the body not to retain the sodium with water. And when the sodium and water is not retained, when the sodium and water retention goes down, blood volume goes down. When the blood volume goes down, the diastolic volume goes down, the preload goes down, and the dilation of the heart decreases. And again, the same process repeats. So this is how the spironolactone works and how the beta blocker works. How beta blocker works. Beta blocker actually, as I already told, there is a beta-1 receptor in the kidney. When the beta 1 receptor in the kidney is increased, then it increases the renin production. So when a beta blocker is used, it blocks the beta 1 receptor in the kidney. So it decreases the renin. Again, it decreases the aldo effect. So it decreases the aldo effect, and again, the same process repeats, and this way, beta blocker can also help in the cardiac remodeling. So that's why they say beta blocker has been used as a major drug to prevent cardiac remodeling in the patient with heart failure. So these are the things, and the beta blocker has also one additional effect, and that is it decreases or controls the heart rate in the patient. So these are the things we have to understand in the heart failure. So these are the strategies, 5 strategies in the management of heart failure. So I think this much is for this video today, and we'll discuss some other topic in next videos. Thank you guys.